Today we are going to talk about heart block. So we know the from electrical system of a heart. This is SA node. This is in the right atrium. This is right ventricle, left atrium, left ventricle. Okay, these are the SA node. This is the AV bundle. Their conduction pathways, right and left bundle. From SA node, we have AV node. Okay, and other fibers. So let us just review that. So, we have the SA node, which is the pacemaker of the heart, the AV node for faster conduction, the atria to ventricles. Then you have uh, these fibers divided into bundle fibers, the right bundle and left bundle. Left bundle has left anterior fascicle, posterior fascicle, and then you have Purkinje fibers. We also know that the SA node has the least latency. That is why it is the top pacemaker. The AV node, we know it is for faster conduction from SA to sinus atrium to the ventricles. And the ventricle fibers have latent but inherent rhythm. Right? So normal conduction pathway, SA node, atrial muscle, AV node, bundle of his, left and right bundle branches and ventricular muscles, and each has a different characteristic. So this ECG, this is very important in the ECG picture. We see that the atrial polarization is characterized by P. It is started by SA node. Then your conduction, the fast conduction, is characterized by the impulse is somehow delayed at the AV node. It comes through the PR interval. Then once the AV node is done, the whole of ventricle will start depolarizing at the apex. So it will give rise to the QRS complex. Then ventricular depolarization is complete. After that, a phase of repolarization will start briefly. Okay, so you have ST, your ST phase will start, and then repolarization will begin at apex, causing increased T wave. So T wave denotes repolarization. And finally, when the T gets over, your depolarization is complete. So I'll review. P wave atrial depolarization. PR denotes conduction through AV node. QRS ventricular depolarization. ST segment would denote a part of end of depolarization and starting of depolarization. And eventually, when T ends, then your depolarization is complete. It is very important to remember this. So I'll repeat, P wave depends depolarization in the PR interval when the passes to R through AV node. QRS will denote ventricular depolarization. P wave will show ventricular depolarization. S waves and these waves are not that much important, but I hope you get the point. So PR interval, what is the difference between interval and segment? So you see PR interval from starting of P to starting of QRS. Okay, while PR segment is end of P to starting of R. So segment is end to start, while interval is from start to start. So this is how we know. So acute interval. So other thing important is whether the ECG reads are placed. Very important. This is very important when you see an ECG next. Always wonder. So here the precordial leads V1 and V2. Okay. Right. Okay. In third intercostal space. V3 is directly between V2 and V4, V4 in the fifth intercostal space, V5 in anterior axillary line, and V6 in left mid axillary line. These are the precordial leads. The post, and these are the limb leads, right arm, left arm, that is lead 1. Left arm, left leg, that is lead 3, left arm, right leg, lead 2. So how do I remember it? So RALA 1L. So you have lead 1, lead 1, RL, sorry, right arm, left leg, so you have 2 L's, so lead 2, and LA, left leg, so you have 3 L's, so lead 3, positive, negative, so that is how you remember the limb leads. Heart block. So after this basics in ECG, you must also review in ECG, because without knowing ECG, it is not possible to review heart rate blocks in particular. Heart block is an abnormal heart rhythm. We know that the pacemaker, the sinus atrial node, actually is the predominant pacemaker of the heart. So heart block is an abnormal heart rhythm. So heart beats too slowly. So either something has gone wrong in the SA node, or it can AV conduction pathway has gone wrong, or something has gone wrong in the bundle branches. Okay. So in this condition, electrical signals that tell heart to contract are partially or totally blocked between upper chamber and lower chambers. Type: first degree heart block, second degree heart block, and third degree heart block. So I'll discuss. So there is a heart block poem. I'll discuss. If R is far from P, then you have a first degree. So it is very simple, right? So if you have PR prolonged, normally it is 0.2 seconds, that is 5 small squares. If R is far from P, you have a first degree. Then longer, then we have two. Then we have second degree. Second degree has some dropping. In the first degree, you only have AV conduction prolongation. Then in second degree, the dropping of the QRS complexes starts, right? And in third degree, QRS is independent from P. So you have, this is the order. In first degree, you have QRS and atrial depolarization are fast. Atrial and ventricular depolarization, there is difference. In second degree, ventricular complex drops, doesn't pass through, and in third degree, ventricle beats on its own and atria beats on its own. So when R is far from P, you have first degree. Then longer drop, then you have Venki back. This is also called Mobis type 1. So you have see PR long, and then drop. This P doesn't conduct at all. Right? If some P's don't get you through, then you have Mobis type 2. So here there is no PR prolongation, but suddenly this thing drops. This is also called group beating. You see, this two together and then drop. Then these two together and then drop. Even in the second degree, you have group. So the PQRs come travel in groups. And if PQ don't agree, then you have third degree. So you have ventricles going at their own rate, and in between the P wave is going on its own rate. So this is third degree and very dangerous. Because ventricle rate is low, right? Around 40-30. It is insufficient to meet blood supply to the brain, etc. And patient will pass out and develop syncope. So first degree AV block or PR prolongation is a disease of electrical conduction system of heart in which PR interval is lengthened beyond 0.2 seconds. That is 5 small boxes. Because one small box denotes 0.04 seconds. Okay. So you see here P. Okay. And here this thing prolonged. It is beyond 5. 1, 2, 3, 4, 5. So this is prolonged. So what are the common cause of first degree AV block? First degree AV block is very common, though, and not that dangerous, because eventually, though it is prolonged, but it does conduct. So you can have either intrinsic AV node disease, or in MI, when you have, say, AV node ischemia. Okay. Then if heart muscle get damaged, that is myocarditis, electrolyte disturbance, hypothyroidism, or some drugs like beta. So it is always good to rule out drug history, to check for beta blockers. You do a thyroid profile, you do electrolytes. So these you can do and check for associated MI, that is ST depression, etc. So as a SA node, normal P wave, long PR interval, and normal QRS, right? Because ventricular polarization is normal, though the distance between atria and ventricle is long. Clinical significance none, treatment doesn't, not required. Then problem starts when it goes to second degree or third degree. What did I tell you in second degree? In second degree, you have the dropping of ventricle complexes start. In first, you have distance between atria and ventricle complex. In second, the dropping starts. So in second type 1, that is also called ventricle, longer, then you drop. That is gradual progression of distance between atria and ventricle, and then something drops. Okay. And in type 2, it is a sudden drop. Right? So conduction through AV node progressively delayed until a drop beats in. Right? While second degree AV block or second degree heart block, here simple disturbance, delay or interruption through AV conduction to ventricle causes again similar beta blocker, but here the heart function is impaired to a higher degree, right? Because the dropping to the ventricle is taking place. There are other infections as well, but again the electrolyte abnormality, hypothyroidism, hyperkalemia are very common. So here also we get serum electrolyte, thyroid. We look for ischemia and everything, and we take a drug history. This is the very common in workup of heart blocks. Then, again, as I told, that PR interval is not constant because longer than drop. And after each drop, waiting, the PR interval is normal, and then cycle starts again. So it is showing that heart system is doing something abnormal. So you see small P, then PR prolonged, and then you finally drop. So clinical significance, you might have significant slight symptoms. Generally, a pacemaker is not required, but you have to watch for the drug history, for electrolyte disorders, for hypothyroidism, for ischemia, and it can predict progress to third heart block. So I'll be very careful in watching this. Right, this is not. I will keep him on monitor. While primary PR prolongation not a cause of much concern, though obviously we should look at the causes. Second degree heart block, that is Mobius type 2. Here, as I said, the drop will be sudden. PR interval is normal constant, but occasionally a drop will be seen. So you see, PR is going here, and then sudden drop. And so this is more significant. Obviously, we are descending down the chain because here it is no more productive. And here again, their criteria, if it is present with other bundle branch blocks, it will require a pacemaker. But again, we will have to watch. Now, third degree heart block. Here, atria ventricles don't talk to each other at all. So, you have complete failure of AV node. No impulse from a sinus node will pass through ventricles. So, ventricle will fly at its own rate, right? At 20 to 30 beats per minute. Sinus will fly at its own rate, PV, at a decreased heart rate. It is also called complete heart block, and the brain supply, the blood is impaired. You must have heard about Stokes-Adams syndrome, right? So here P wave rate is normal, ventricular rate is low, around 40, and ventricular complex may be broad, actually idioventricular rhythm, right? QRS is broad, and there is complete dissociation between P wave and QRS, also called as AV dissociation. So you see, this is broad, this is going at its own rate, P wave going on its own rate, QRS going on its own. And here significance, it can lead to standstill, VT, Stokes-Adams, symptom loss of consciousness, confusion. We immediately give atropine, when we start for pacemaker. Initially we put a temporary pacemaker, and then after 3-4 days, we can put a permanent pacemaker. This is not very costly. This costs around 70,000 to 1 lakh, and it is available in the market. Okay, so that is important about this heart blocks. So the underlying thing is to understand the heart block symptoms, to degrees of heart blocks, and which is more severe. If heart rate is low, you got to characterize the blocks by watching a relationship between P and QRS and the treatment there. Okay, I hope it helped.